much, Janet. I really appreciate the introduction. Hello, everybody. Good morning. Thank you for inviting me here to talk today. I see a couple of familiar faces out there. I am Dr. Warren. I'm with Apollo Pain Management here in Sun City Center. I already started up the stuff, huh? So that's me. That's a little bit of my bona fides. It's a lot of school I went through. So just a little bit of proof that I know a little bit about what I'm talking about. Go on to the next slide. I am a veteran too, so for all you vets out there, we love to have you guys come stop by the office. We have a very high contingency of veterans in our practice. We like to keep that. We're one of the few offices around here who actually takes TRICARE. And we also take the VA. I'm one of the VA certified docs. And as you can see, I'm also a vet, and I had 2 tours in Iraq. So for all you guys who toured at some point, here's to you. Next slide, please. All right, let's talk a little bit about pain medicine, okay? How many people out here actually have pain? Yeah, I expect everybody's gonna, me too. All right, you get to a certain age, it's just unavoidable. It sucks, but we're not 20 anymore. I say we. And there's basically 4 ways to treat all pain. We got lots and lots of different ways to treat pain because there is no such thing as a single medication, a single therapy, a single intervention, or a single surgery that's going to treat every single pain. It just doesn't exist. So sometimes we got to tease this out about what's causing your pain. We'll go over this a little bit. Okay, next. So the first option for pain is the medications. It's the first stop for everybody, and it makes sense. It's usually the last stop. Okay, most pains can be controlled, and that's what we're talking about: controlled, not cure. There's no such thing as a cure for pain. I know a lot of people. I get this every single day. Somebody comes in, hey, is there any way I can get rid of this pain completely? My answer is always no. We're going to try to manage your pain. We're going to try to get it down to a better livable level, but to get rid of it and cure it doesn't happen. But frankly, medications help a lot. You know, I got an ache, I got a cramp, reach for the Tylenol, that's all you need. You really don't even need to come to something like that. But there's lots of different ways. NSAIDs are ibuprofens, naproxens, Motrins, that sort of thing. Some of you might be on Celebrex or Meloxicam. Those are all NSAIDs. They're all in the same family, just different formulations. Muscle relaxants can be very good for cramping type pain. Neuropathics like gabapentin and pregabalin are good for those pains that when you have something going down your arm or down your leg, the sciaticas, which afflict a lot of us, including myself, can be very effective. Now let me talk a little bit about opioids. I got a lot of patients who are on opioids and a lot of patients who want more opioids. And let me educate everybody on this. Opioids, here's the thing. Do they help with pain? Yes. Are they good for long-term pain? The short answer is it depends. The deep answer is you want to be very, very, very careful with them, okay? I've had so many patients come in and say, hey doc, these opioids really help my pain. I'm on these opioids, but I don't want to take that gabapentin because I read the side effects and I don't like that. Those side effects look pretty scary. The side effects of opioids are scarier than any other pill, okay? So yes, they can. I know there's a lot of people around them chronically, but I know most of you are going to be taking it very, very carefully, as you should. But the side effects of opioids are should be taken very, very seriously. And so that's why we work very hard at the office. If you're on opioids, we tend not to go up. And we try to come down and find other methods to get your pain under better control so we can decrease your opioid load and hopefully get you off, which we have been successful with. And every time we have, the patients actually end up feeling better. Because the other thing about all of these medicines, but especially opioids, is they all have side effects. Some of those side effects are, I just can't think as well, I'm constipated all the time, I just feel run down. We drop the load, you still have just as good a pain control, but now you have fewer side effects. So if you come to my office and we talk about it, don't think if I say, I start talking about decreasing the amount of opioids you're on, don't think I'm trying to take away your medicine. What I'm trying to do is improve them. Okay, next slide, please. Okay, one of the other things to help with pain, therapies. I was just talking with somebody about physical therapy. Extremely effective. I'm a very, very big advocate of therapy because moving is what we need to do. The more you move, the better you're going to feel in general. Okay? Now, a lot of people come to me and say, hey, Doc, I've tried physical therapy, it doesn't work for me in the past. It's like, okay, well, we get into the conversation. Most of the time, not always, but most of the time when they've gone to physical therapy, what they mean is, I saw some exercises online and I tried it. And it just didn't work for me, Doc. Well, when I say physical therapy, I mean physical therapy with a physical therapist. Okay, and the reason that is because, yeah, Doc, I'm doing the physical therapy, it tells me to turn my head and go like this, and it just doesn't work. It's like, well, if you actually talk to a physical therapist, they'll watch you and they'll say, no, turn your head this way, put your hand over here, and then, maybe do something else, and then you're like, oh, now I get it. It's basically the same reason why professional athletes have coaches. I mean, we all know, they know how to work out, they know how to exercise. Why do they need a coach? Well, because they need somebody to watch them and make sure they're doing it correctly. Same thing with physical therapy. You can't just do the physical therapy, you gotta do it correctly. Okay, let's go on to the next slide, please. All right, surgery, generally the last resort. I have a lot of surgical colleagues that I am very, very respectful of. They do a great job, and when you have something specific that you can point to and say, hey, that's the problem, that little disc, that disc bulge is pinching on that nerve. If I relieve that, I can probably relieve your pain, in which case surgery is probably what you need. Okay. However, a lot of patients, especially as we get older, we're not candidates for these sort of things. Going under the anesthesia is going to just be too much stress on the body, so you might not be a cancer. Also, you've got to remember that once surgery is done, these are generally irreversible, for the most part. So once it's done, it's done. Once you've had a knee replacement, your knee is replaced. Once you have a hip replacement, your hip is replaced. Okay? Surgery is not something you want to take lightly. If it's necessary, then of course, I think it should be done. But never ever undergo surgery without a lot of thought. And your surgeons, the good ones, will absolutely 100% respect that. Okay? Next slide, please. Okay, let's get to what I do. Interventions. We're talking about steroid injections for the most part. Steroid injections, to start off with, there's lots and lots of different types of interventions, and what we use kind of depends on the type of pain you have and the location of your pain. The advantage of these interventions is it actually puts the medication where the pain is at. Okay, Doc, I got a pain, it's only in my back, but I'm taking a pill which goes to my entire body. Or it's only in my knee, but I'm taking a pill that goes to my entire body. Well, we take those medications and just put it right where the pain is. Steroids are basically anti-inflammatories, but they're much more powerful than your NSAIDs, your ibuprofens, your Tylenols, and things like that. And we can bypass the bloodstream and everything else and just go right where the pain is. Could be very effective. Disadvantage of these, oftentimes they're of short duration. Some of my patients will get months of relief, which is great. Sometimes you only get a few days, in which case we got to think of something else. Okay, next slide, please. So here's a little example of all the different types of things we can do. Muscle relaxants, joints, spines, radiculopathies, nerve pain. All these types of things have different approaches. Next slide, please. Okay, for joints, generally, you come into my office for the first time, I got a pain in my shoulder, I got a pain in my knee, I got a pain in my hip. Generally going to start off with a steroid injection to see how you do. Okay, if you've already had one, you already know how you're doing, maybe we can skip on to the next thing. Steroids can be very effective. If they don't last long enough, there's something called hyaluronic acid, which especially is good for the knees. The nice thing about the steroid and the hyaluronic acid interventions are they're both covered by insurances. The PRP and the stem cell, which some of you all may have read about or heard about, PRP is platelet-rich plasma, which we basically take your own blood, spin it down, take the portion of that blood, and we inject it into the area that's painful, and it can actually cause some actually regenerative effects. However, it's not covered because mostly because the insurance don't want to pay for it. But the thought is that it has not been shown to be scientifically correct, or effective, rather, is my word I'm looking for. I don't agree with that with regards to PRP. I think that might be fairly accurate with stem cell. Stem cell is a very promising therapy, but frankly, the data is still out, and that's why my office really doesn't offer stem cell or PRP, really, but mostly because of where we're at. Neither one of those therapies are covered by insurance, and they are extremely expensive. So if you go that route, you just keep that in mind. Next slide, please. So what about spine pain? That's what most of us have. Neck pain, especially low back pain if you're like me. That's generally going to be caused by a standard run-of-the-mill arthritis, facet-mediated type pain, which is joints in your back. We treat this also. We start off with injections. Medial branch blocks are what they're called, but basically those are injections to the nerves that go to those joints, and we see how you respond. Again, we like to see 75, 80% relief. Okay, we can get the back pain down significantly if this is the cause of the pain. And some days, some of my patients, they'll get 3 months. I got a couple of patients getting 6 months and more of relief with injections alone. It's fairly rare. The more commonly, the patients will only get maybe a few days or a week or so, in which case we need to do something else, something like a radio frequency ablation. And what that is we put the needles in the same spot, but instead of injecting a steroid or a local anesthetic, we inject electricity and we heat the area up and we ablate the nerve, or basically burn the sensory nerves away from the joints. And that can give much longer relief. 6 months, a year, sometimes 2 years. And it doesn't last forever usually, because the nerves do eventually grow back. And when they grow back, the pain can come back. Okay, next slide, please. Nerve pain. So there's lots of things we can do for nerve pain. Everybody's heard of epidural steroid injections. That's something we usually start with. Depends on what the pain is caused by. If it's caused by radiculopathy, which is a pinched nerve, the epidural steroid injections can be very, very effective. However, if it's caused by something else, diabetes or maybe poor vascular flow, we might have to think of some other types of things like direct peripheral nerve injections, or even sympathetic block, which is a different type of centralized nerve injection. And then, of course, there's advanced therapies we can offer for this same type of stuff. Next slide, please. Some of those advanced therapies, those are for the things that don't respond to the more conservative things, the standard injections, okay? We do a couple of injections, we do a couple of ablations, it's just not lasting. So what can we do? There's neuromodulation, which is basically, we're trying to use a device to inhibit the nerve signals getting to your brain. Kind of works like a pacemaker for your pain. Okay, that's concluded under spinal cord stimulators and peripheral nerve stimulators. There's SI joint stabilizations or fusions. That's for sacroiliac joint pain. And then, of course, we have mild procedures, interspinal pacers, and the only acute pain we treat are for compression fractures, and we can do a kyphoplasty for that, and we'll get to that at the end. Okay, next slide. Okay, a little bit about spinal cord stimulators. So spinal cord stimulators, as I said, they work kind of like a pacemaker for your pain. When somebody has a bad heart and their heart rate is irregular, it's going bump, 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 they put a pacemaker in there. It's a small electrical device that provides an electromagnetic field which interrupts the pathological signals and allows the good signals through, and it turns that beat into a nice bump, 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 bump. That's how pacemakers work. Stimulators work very similar. When we have a pain that's going down our legs, that pain signal is going from the legs up into the spine and reaching the brain as being perceived as pain. We put a stimulator in between that pathway, and we inhibit those pathological signals. And it can have a tremendous effect on reduction of your pain, reduction of your pain medications that are required, improvement of your function, and it works for several types of neuropathic pain. It works for radiculopathies, diabetic pain, vascular pain. So it can be very, very effective, and it can last for years. And the nice thing is, it can also this is one of those few procedures that is 100% reversible. So if at some point it becomes a problem, it can always be removed. And the other nice thing is there's a trial involved So this is not something where somebody says, hey, I think you need a spinal cord stimulator, and we drop a spinal cord stimulator in your body, and now you got this thing in your body, and maybe it'll work and maybe it won't. There's a trial involved where we place the leads and you walk around for a week and you come back and you tell us, yeah, that really helped. Or, no doc, that really didn't do much for me. In which case, we take the leads out. It's like they were never there. So it's nice to be able to know that before we place this thing, it actually should give you some kind of relief. Okay, and as you see, the success rate is pretty effective for long term. Anywhere from 50 to 80% of patients who try the trials move on to a permanent. Peripheral nerve stimulator, very similar, only in the peripheral nerves. Okay, that means maybe you just have pain in your knee, or you have pain in your foot, and we can do a peripheral nerve stimulator. This device, actually, the battery is not even implanted. It's simply a wire. It's an external battery that you wear over an antenna, and you don't have to wear it all the time. You just wear it when you have the pain. Okay, so that's something else. Next slide. Okay, interspinal space. Let's go on to the next slide. I think we're running out of time. Mild procedure. So, some of you patients may have had, some of you may have been told, hey, I have pain going down my legs because I have stenosis in my back. Okay, what is a stenosis? Stenosis is when there's a squeezing or tightening of the spinal cord from some obstruction like this. Okay, that it is squeezing on your spinal cord. Okay, so the fix for that is to relieve the pressure. Well, one of the ways that a surgeon will do that is he'll cut your back open and he'll take the back of your spine off, and that'll relieve your pressure. Okay, that's one way. A less invasive way to go is a minimally invasive lumbar decompression, and that is depending on what's causing the compression on your spine. Okay, if it's coming from the posterior part or the back part of your spine, like up in here, we can take a small device and go in and basically, it's like a little tiny ice cream scoop, and we scoop that tissue out, and it's through a tiny little incision about this big. Okay, you don't even have to go under anesthesia. It's under a sedation like you would get from a colonoscopy. Okay, so we're not talking about tubes down your throat or anything like that. We're talking about just a little bit of sedation. You fall asleep, you wake up, it's over, and there's a tiny little incision about that big on your back. You walk into the procedure, you walk out of the procedure. The recovery is almost the same. Now, it might take, most patients have had this for about, by the time they come to me, they've had this for anywhere from 2 to 10 years or more. So I try to tell the patient, you're not going to expect instantaneous relief once we relieve this pressure. It could take weeks, maybe a couple of months before you see improvement. But even if you don't see improvement, there's always you can always have the surgical option. And if you do see improvement, you've just avoided a pretty extensive surgery. Okay, next slide, please. Okay, SI stabilization, also known as SI joint fusions. This is excellent for an underappreciated cause of back pain. A significant cause of back pain is actually coming from your sacroiliac joints, which is the bottom of your spine here. This is your sacrum, that's your ilium, that's your sacroiliac joint. And it's a significant cause of pain for a lot of people. Usually it's described as pain in the low back, can often be confused with lumbar type pain. So we got to do a little exam to find out, if this were likely your source of pain. And the pain often radiates down into your groin, sometimes down your leg, but usually it doesn't go past the knee. Now, so a lot of patients come in and say, hey, I have sciatica. Well, that's not really a sciatica, that's a pseudo-sciatica. Sciatica is when your sciatic nerve itself is being pinched in the lumbar area, usually from a disc herniation or disc bulge. And that pain generally is described, it goes all the way down your leg to your ankle, to your foot, to your toes. That's a pinched nerve. Pseudosciatica is if the sacroiliac joint is inflamed, the sciatic nerve actually travels right past that nerve, that joint, and it can become secondarily inflamed, and you'll feel pain going down your leg, but it usually doesn't go past your knee. That's a pseudosciatic, and that's a telltale sign telling us there's a good chance that pain is actually coming not from your sciatic nerve, but from your sacroiliac joint. And there we do a couple of things to To verify that, usually start off with a sacroiliac joint injection, and then we'll move on from there. There are other options, an ablation, and of course a sacroiliac joint stabilization or fusion is where we place a small bone dowel right there in the joint, and what that does is it kind of distracts that joint open a little bit and relieves the pressure of the nerves. And after a few months, the expectation is that it will fuse and it won't have that movement anymore, causing the irritation. Okay? And it's got a pretty good success rate, anywhere from 77 to 85%. My success rate is probably right around there, 80, 85%. Why doesn't it work on everybody? Well, because you have to have that bone placed exactly right. If you only like it to pop open just like that, if it only pops open like this or like this, then you might not get the relief you're looking for, in which case there are other options that we can try. Okay, among them, the ablation, as we talked about before, and neuromodulation as well. Next slide, please. Compression fractures. Okay, so a lot of you probably know somebody who's had a compression fracture. Again, this is the only acute pain that we treat. All the rest are chronic pains, meaning you've had that pain for at least 3-6 months or longer. Okay, if you have like, oh, you know, my knee's been bothering me, how long? Oh, just a week or two. You probably don't need a pain doctor. You probably need a Tylenol or a little rest, maybe some therapy, you know, but you don't need a pain doctor for something like that. Now, let's say that you know, you're walking along and you fall, and now all of a sudden you have a very sharp stabbing pain right there in a specific spot in your spine. Well, that might be a compression fracture. That's acute, and that needs to be taken care of. Because if it's not, it can become a very nagging, chronic pain for pretty much the rest of your life, and it's very, very difficult to treat once that bone is healed. So, the compression fracture, this is a picture of one right up here. It's basically it's a break, you broke your spine. That's what it is. The vertebral body up there has a crack in it. Some of the pieces might push back on the spinal column, which can be a problem. And it's usually caused by lots of things. Osteoporosis is the most common problem, and that's pretty common among us. Okay, I'm in that age group too now, guys. Can cause by injuries, car accidents, falls, tumors that get into the spine, that can be associated with it as well. This can occur very innocuously. Now, people might not even know that they have a fracture because nothing happened. I haven't had any falls, doctor. I don't have cancer. A doctor, they say that my bones are pretty strong. I have, you know, osteopenia, but not osteoporosis. But you can get this from sneezing. Okay, I've seen patients come in and say, well, what happened? I sneezed really hard about a week ago, and it's been nagging me ever since. You gotta get an x-ray, lo and behold, you got a compression fracture. Rolling over in bed, that's also common. I rolled over in bed, I felt this stabbing pain in my back, and it's been killing me ever since. Okay, so be aware that these are things that can happen, so that, and maybe it's not just, oh, I'm just, you know, I might just got a little muscle spasm back there. It might be something else. Okay, next slide, please. Okay, so it's just a little bit more stuff about it. What happens if you don't treat it? Bad stuff. Lots of chronic pain. You can become kyphosed a little more, which basically means leaning over a little bit more. You could have GI problems, breathing problems over the long term, okay? And these are things you want to be treated within the first 2 to 3 months. After about 6 months to a year, certainly after a year, there's probably not much we can do, okay? Because the bone is healed at that point, and it is what it is. Either your pain has gotten down a little bit, or now it's the same as it was before, and it's probably not going to get much better. Okay, so this is something you want to get on quickly if you actually end up having one of these. Next slide, please. So how do we treat it? Well, one of the ways you can treat it, this is kyphoplasty. One of the ways you can treat it, sometimes you can just treat it conservatively. You know, maybe you're not having too much pain. We can just put you in a brace for a little while, give you some medications, and you'll be fine. That actually does happen and does help patients in about 20% of the cases. Frankly, in my experience, usually we need to move on to a kyphoplasty because the pain's that severe. And this is what a kyphoplasty is. We place a small needle, actually it's a large needle, to be honest with you. A large needle goes into that bone. We put it down right into that bone, we create a small space, and we place a bone putty right into the bone, and it hardens kind of like a cement and supports it. It's a great procedure because patients will get immediate relief. They'll walk out usually feeling much better. Next slide, please. And this is just a little cartoon of how that works. This is the needle going into the bone. We open it up, make a space either with a balloon or some other device. We put the putty in there, and then it hardens up. Okay, next slide. This is just a little information about how much better people do. It doesn't take away all your pain. Again, I want to repeat, nothing takes away all of your pain. Okay, this is still a broken bone. If we can get your pain down by 70, 80%, we call that a success. Okay, plus, let's face it, in our age group, if we have a fracture and we heal it and that fracture feels better, we still have other pains around it. Okay, that's just the way it is. All right. Complication rate on this procedure is very, very safe. Less than 4%. Frankly, my experience has been much lower than that. And it's one of these procedures that's very nice because we can do it right in the office. It's basically an injection. It's a high-end, or it's a high-end type of injection, but it's an injection. Okay, next slide, please. Oh, that's it. All right. So here we are at the end. A lot of information. Any questions? One guy.
Okay.
I think we have a.
I'll speak loudly.
All right.
Here you go, Carl.
For years, I've been reading about next generation analgesics that are derived from snake and other venoms. Any progress there?
Snake and other, not that I'm aware of. Okay. There's lots and lots of research that's going on, but it's very much like the stem cells and the PRP. PRP is actually an established, has a lot of data behind it. It does show good efficacy, and it's got to the point where I'm actually convinced there's something behind it, and I think it's worthwhile. However, PRP is still, even though it's been shown effectively in all the medical journals, still not covered by insurances. Stem cell. Why am I saying stem cells? Because you're talking about something experimental, snake venoms and things like that. Anything experimental is not going to be covered by your insurance. Okay, it simply won't be covered. Now, does that mean you can't have it or can't use it? You can always pay out of pocket. My office is not really doing experimental type of procedures for two reasons. One, they're all very expensive and most people can't afford them. And two, I like to use stuff that's only been shown in peer-reviewed journals to have efficacy. And that's why I don't use stem cells at all. We are looking at, my new doctor, he's very much into PRP and regenerative medicine. We will probably be adding that to the repertoire in the office. But currently we don't have anything with regards to like stem cell or snake venoms and things like that.
Compressed fractures show up on x-rays?
Sometimes they don't, actually. Most of the times they do, and it's usually fairly obvious. But if they don't, the gold standard imaging study to find out if somebody has an acute, meaning a recent compression fracture, is going to be an MRI. So if we see a compression fracture on an x-ray, but you're not having pain where that fracture is, it's likely an old fracture, and you don't need a kyphoplasty. The pain's probably from something else. However, if we see a compression fracture on an x-ray and you do have pain in that area, then the next step, in most of the time, is to get an MRI to determine several things. First, that'll help us tell how old the fracture is. Okay, if it turns out to be it's at least 9 months, 12 months old, kyphoplasty is not indicated because it won't help. But if it's recent, then it could help.
Okay, would you explain to us about spinal block?
Which spinal block? Do you mean like a medial branch block or an epidural steroid injection? Or when you say spinal block, that's pretty generic. So do you have a specific one in mind?
I'm not sure.
Did you have one recently, or is it one?
No, I'm scheduled to have one Wednesday.
Wednesday. It's a spinal block, and what is it for? Maybe I can help you. Is it for
It's for pain.
Is it pain? Is it just in your back, or is it going down your leg?
It's going down my leg,
Okay,
especially
so-
to my ankle.
So it's probably an epidural steroid injection, is what you're probably doing, okay? And that's where we place a needle in the epidural space. Many of you ladies probably already had one of these done when you had babies. Epidurals are done all the time in the hospital, where we place a small catheter and give you some medication through it. It's very similar to that. We place the needle in exactly the same space. It goes into your spine, but it doesn't go into your nerves itself. What it does is it goes into the epidural space, which is the space surrounding the spinal cord. And we inject the medication in there, and it surrounds the medication and decreases the inflammation. Okay? That, when effective, can give you several months of relief. And sometimes you only get a couple of days of relief. And if you only get a couple of days, then they're going to have to think of something else. And that depends on what your MRI looks like and on what they think might be causing that pain.
What if you can't do an MRI?
If you can't do an MRI, I was hoping somebody'd come up. There are other imaging studies that we can do. We can do CT scans. We can do CT scans with myelograms. Sometimes, for example, if we need an MRI for the compression fracture, but you can't do an MRI, well, then we'll do a bone scan instead. Okay, because then we're just looking for how old is that fracture. But for something like you, if you can't do an MRI, they can usually do a CT scan. CT scans are much easier to take. They're much, much faster, and they don't have to put you in that tiny little tunnel. You go through that big donut-looking thing, and there's usually not a problem with claustrophobia with that. Yes, sir.
Your
I-
slide,
Hold
your
on,
slide.
hold on. I've
Yeah.
had several spinal ablations, and I'm scheduled to have a trial where they put the subcutaneous wire in there.
Mhm.
Couple questions. Is that, when they put you under, is that usually an intubation procedure? And how long does it normally, that procedure, take to perform?
Well, it depends. I'm not sure if we're talking about a peripheral nerve stimulator or a spinal cord stimulator. Do you know which one? Where are they putting it? Are they putting it in your spine, or are they putting it in your tissues somewhere? You're not sure.
Not sure. I believe it's spine.
And the other question is, are you going in for a trial, or is this the permanent placement?
This will be a trial, 5-day trial.
A trial. And where are they taking you? Are they taking you to be done in the office, or are you going to be done at a surgery center?
In the office.
In the office.
I'm sorry, surgery center.
A surgery center. Okay. It depends on what the anesthesiologist and the surgeon agree on. Okay. Really, it's up to the anesthesiologist in the end.
Well, I've been told I can have it done local or go under.
Okay. Good. And so that'll give you your choice. A lot of times, just a little bit of sedation is fine, like a colonoscopy. So they'll give you an IV, they'll give you some propofol, the white stuff, and you usually wake up feeling pretty good from that. Depending on the anesthesiologist, he might prefer you be completely under and not move at all, in which case they might intubate you, but that'll depend on your medical conditions and your heart, your lung capacity, and whether or not you can tolerate that. If you can't tolerate that, they'll keep you under sedation. Or if you're a tough guy, maybe they'll just give you a little bit of local anesthesia and they'll keep you awake.
They told me it's about an hour procedure.
It's about an hour procedure. They'll probably give you a little bit of sedation for that.
Okay.
Okay.
And that's usually an intubation?
No. A sedation, usually there's no intubation. Just a
Okay.
little bit of gas. They give you an oxygen mask, and they just watch you.
Okay.
And they keep an eye on all your vital signs and make sure you're safe.
And what are the percentages of success from that type of when they get to permanent?
From the procedure, I'd say I convert somewhere between 70 and 80% of my patients from a trial to a permanent.
Okay. And that lasts?
That's the nice thing. So this is the dirty little secret about pain that I think we already know. Pain always changes. Okay, your pain last year is probably going to be worse than your pain this year. And that's what can happen after we place the spinal cord stimulator. We place the stimulator. Hey, it feels great. I love it, doc. Thanks. You're the best. 6 months, a year, 2 years later, this thing sucks. It doesn't work anymore. I hate it. I wish I had it out. Well, maybe you just need it adjusted. Maybe you just need to have the power cranked up a little bit, or the frequency changed, or something else. I've lost count of the number of patients who came into the office and told me, hey, my spinal cord stimulator's not working anymore. I need it out. Before we get it out, why don't we have the rep come in, play with your adjustments, and see if we can recover your pain. And we do. Not every time. Sometimes it's like, no, this thing ain't working anymore. Or not, no, it's not true. It's not working anymore. It's not covering your pain anymore because your pain has evolved. It's gotten worse. It's involving more nerves that weren't involved before. So that's the thing you need to understand is nothing stays the same. There's a reason I don't see any brunettes in here. One. I see one.
I understand.
Same here.
I understand.
Mine used to be much longer and brown and beautiful, but now, not so much.
I understand that the procedure is not, you're retired military, so you have TRICARE also.
Actually, I do not. I didn't retire. I got out after about 15 years.
Okay.
I was an idiot.
I'm retired and I have Medicare and TRICARE, and I've been told that TRICARE will not cover the trial or the permanent part.
Yeah, that's true.
Is that something that is going to change?
Honestly, only if you people make it change. And me too. All right, I've already written my congressman. Continue to write him. Let him know. I'm not going to let this get into a discussion about insurance because
Okay.
you don't want to hear me talk about insurance, least of all TRICARE, because I am a vet, and it pisses me off how poorly TRICARE treats their patients. You might be, I know, my father had TRICARE. He loved it because it covered all of his medications. But he really didn't need any surgeries or any procedures.
Wow.
Yeah. Well, yeah, he was Army too, and he
Understand,
yeah.
understand that this vet is trying to do his part to help you.
Outstanding. And I appreciate that because it's terrible. I don't want to get on TRICARE either, but not a fan of how TRICARE treats their vets. Yes, sir.
Dr. Warren, very informative. I'm a note taker, but I could not follow it fast enough. Do you have any handouts?
We have. Well, we're going to give out. We're going to give out
For the slides, yes.
Yeah, we're going to give out the slide itself. We're going to post that, right? We're going to post that on
Yes,
the web.
future and Ragnarok.
Okay, so you can
Perfect.
you can
Thank you.
pause it and all that kind of stuff. I'll have to think of. I didn't think about bringing notes. I'm going to do that next time. We do have some information on the office over here. We have some flyers and some handouts if you want to know where we're at. I'm literally about a 2-minute drive from here. That's about how long it took me to get here. So maybe 3 minutes by golf cart. Okay, and we got plenty of parking and golf cart friendly, so pretty easy to find. Oh, yes, ma'am.
Well, as you know, I'm a patient of yours.
Yes, I know you.
And I had a lot of pain in my knee.
Oh.
It's all gone. You helped me.
Thank
That's
you
all I can
very
say.
much. I appreciate. It's still feeling better. All right, that's what I like to hear. All right, that's the story we're looking for. When patients come into the office, you'll probably come in several times. We'll do a couple of injections, a few things. My goal, eventually, is to only see you at places like this, or over at the German restaurant, or something like that. That'd be great. Okay, that's my goal. It's not to keep you coming back for more injections, although sometimes that's required. The goal is to make you feel better, go off, live your life.
Can you discuss acupuncture with back pain and sciatica?
I can discuss it a little bit because I'm not an acupuncturist. However, if you want my opinion on acupuncture, I think there's something to it. I have several patients I've sent to acupuncture. I'm not going to explain it because I'm not an acupuncturist. I don't understand Chinese medicine. It's not performed the way we think of things in Western medicine. It's very Eastern. It's regarding the flow of qi and the meridian channels and things that I really don't know much about. However, what I do know is that I've had patients who I have failed with, that I haven't been able to help. And I send them to acupuncture, and they come back and like, you know what, it actually helped. Now, is it a miracle? It's like any other treatment. It falls right on in here. I put it under therapies. It doesn't work on everybody for every pain, okay? Somebody tells you they will, don't go to that guy, okay? It's just not true, but it still can work, and it can help because I've seen it. I've had acupuncture done on myself. I had acupuncture done on 3 times, worked twice, didn't work on the other time. And so there is something to it. And so I don't do acupuncture in my office, but I will refer out to, I got like 2 or 3 acupuncturists that we refer to.
Is the same true with chiropractic?
I would say yes. I would say yes. There's a place for chiropractors. I have a lot of respect for chiropractors. My only caveat to that is those who see chiropractors, please have caution with the neck. They do lots of good work peripherally in the lower spine and thoracic spine, but we have seen issues when people get chiropractic work done on their neck. And so you got to be very careful with that. I'm not saying that they can't work on your neck. I'm saying just please be cautious with that. And yes, we have sent people out to chiropractors. We've had people come to me who've already been seeing chiropractors. They get some relief. They're looking for a little bit more. Any other questions? Well, this has been a pleasure. Thank you very much for allowing me to come and talk to you. I hope you learned a little bit. I hope it was helpful and informative. I hope you enjoyed it somewhat. And if you have any issues, and again, if you need anything, you can always give my office a call. I have a little bit of information down here. And once again, thank you, and you all have a good day.